It's now my pleasure to introduce Professor Tatjana Milenkovic from Macedonia. Professor Milenkovic is a professor of internal medicine, works at the Clinic of Endocrinology, Diabetes and Metabolic Diseases, established Department of Education of People with Diabetes, and she is the head of the department, President of Macedonian Diabetes Association, and President of Macedonian Scientific Association of Endocrinologists and Diabetologists. Professor Milenkovic will talk about new horizon in the treatment of diabetes and obesity. Please, Prof.
Thank you so much for kind introduction. Before I start, I have to admit that I cannot agree more with the first two speakers that regarding obesity, like diabetes, like many things in the life, education or lifestyle changes is the most important thing. Less calorie intake and more physical activity should do a miracle in those patients, but we have to admit that obesity is a kind of addiction and sometimes is very, very difficult to treat obesity just with lifestyle changes. So we need to do maybe something more. And because recent years, the whole science is focused a lot on obesity, I will try to update you what are the new horizons or what we should expect in the next couple of years in the field of treatment of obesity. We know that obesity is a huge problem. Professor Inas, she has newer data that maybe more than 800 million, she said, living with obesity. And what is devastating in the number of younger population, that there are the higher number of young people with obesity. And it is a very difficult state because of it is so prevalent, it is so many complications, and finally because it shortened life. And those with a severe obesity, just half of these people will reach 70 years of life, which is very short for this 21st century, of course. And when we are speaking for pharmacological measures or treatment for obesity, for now, approved treatment for obesity are these couple of drugs: naltrexone bupropion, phentermine topiramate, liraglutide and semaglutide, and finally orlistat. And if we look a little bit what is their efficiency what will be the percentage of weight loss from the start weight loss, we can see that for this moment, the best is semaglutide, that the patients can lose up to almost 17% of initial body weight. But the question is there something new on this horizon in the treatment of obesity? So that's why the focus on this year's guidelines are absolutely on treatment of obesity, because it is considered with the level of evidence A that it is enough even for patients to lose 3 to 7% of initial body weight, but it will be even better if they lose 10% or even more, because they can reverse diabetes and they can stay in remission a very long time with just with reducing the body weight. So what will be the new treatment? The new treatment will be combination or multi-receptor agonism between GLP-1, GIP, and glucagon. And I will present you a couple of drugs that some of them are just before approval, and some will be approved in the next years. And we will start with tirzepatide, that we are expected to be approved by FDA to the end of this year for the treatment of obesity. We know that it is combined GLP and GIP drug, and it is administered also once weekly injection with starting dose of 2.5 up to 15 milligrams. And it demonstrated even in the first phase when it was considered just a drug for treatment of type 2 diabetes that it can reduce significantly weight loss. So it can induce weight loss. So this is the results of the Surmont trials, which were specifically designed. Surpass was for efficacy in type 2 and Surmont in efficacy in obesity. And here we can see that dose dependent, it will, the patients on this treatment can reduce their body weight up to 20% of initial body weight. And it is very similar with 2 doses of 10 and 15 milligrams of tirzepatide. They can reach a significant weight loss for almost 20%. And this is the last study. It was phase 3. In Surmont 2 study, it was shown that 10 and 15 milligrams of placebo, the endpoints was body weight change from baseline, and what was the percentage who achieved more than 5% body weight reduction during study. And you can see there that there is an excellent response on this dosage, that the patients are losing 15%, and even almost 80% or 90% of persons will lose more than 5% of their body weight on this treatment. So this was the primary endpoint that was reached in majority of patients, and you can see that even 10, 15, and even 20% of initial body weight was reached in almost 50% of patients on this drug. And at the same time, this drug is very effective in reducing the HbA1c, approximately 2%, even more in some trials, which is really a great benefit for patients to improve their metabolic control and in the same time to lose a significant amount of weight. The second drug that I will speak about with this oral semaglutide, which is in a third phase of development, OASIS 1 trial. It was almost, the studies are with the same design. They're examined the people between 27 and 30 BMI when the drug were recommended. So the dosage for losing weight of oral semaglutide is 50 milligrams. And we know that for diabetes it's just 14, so this is a higher dose. And also the endpoints of the trial was body weight change to the end of the trial after 68 weeks and achievement of more of 5% of initial body weight. And as we can see, that the mean baseline body weight was around 105 kilos. At the patient, at the end of 68 week, majority of them were able to lose up to 17% of initial body weight, which means that this is very good results with oral semaglutide. And for me, what is very important in this trial, diabetes type 2 was excluding criteria. So all patients were with pre-diabetes. And what is very important, after 68 weeks, as you can see, all patients were in diabetes remission. Even 2% were just 2% below 6.5, and all others below 6.5%, and some of them even below 5.7%. So it means that this drug can even postpone the onset of type 2 diabetes if the patients lose enough amount of weight. Then another drug is orforglipron, which is in phase 2 of obesity trial. This is a non-peptide and small molecule GLP-1 receptor agonist. It is also examined, it's studied with the similar design, this is given orally, before it was semaglutide was orally, and this one. The dosage are from 12 to 45 grams, and the primary endpoints were quite similar to the previous trials. And here we can see that even the last three dosage, 24, then 36 and 45 milligrams, were able to demonstrate the body weight loss up to 15 almost % of initial body weight. Regarding the adverse events, there were minor adverse events, gastrointestinal, and they were more of the mild or moderate adverse events that are characteristic for all class of GLP-1 receptor agonists. And I will show you two more. This is first survodutide. This is a combination of glucagon and GLP-1 receptor agonist. It is the same design of trial with dose from 0.6 up to 4.8 milligrams combined, in comparison to placebo, also weekly subcutaneous injections. And also it was measured the percentage of body weight in comparison to initial body weight, and also percentage of people who were able to reduce their body weight more than 5, 10, and 15% to the end of the trial. So these were the results that the same like the others. The last three doses, 2.4, 3.6, and 4.8 milligrams, are with average loss of weight 12.5 to almost 15% of initial body weight, what is very good result. And weight loss of at least 10% was reached by 68.8% of participants in these trials, and even in those of 4.8 milligrams, there was a 15% or more achieved, and half of the 54% of examined patients with diabetes, so with obesity, sorry. So it means that there is a really good results with this drug. Adverse events are also the similar that we are seeing in the other groups, the other medications of this group of GLP-1. As I said, it is combination with glucagon. And I think so that it is the last one who is the most promising, retatrutide, and it is a triple combination of GLP, GIP, and glucagon combination, and the more potent there is GIP in this combination. Also was the trial of around 388 patients with BMI between 27 and 30, and initial dose was different. Some of them started with 1 milligram, some with 2 milligrams, and then the dosage was gradually enlarged, so up to 12 milligram of dose weekly for 48 weeks. Primary endpoints was also percentage of body weight changed at the end in comparison to the beginning, and the secondary endpoint was what the patient's body weight reduction of over 5, 10, and 15% was seen in how many patients included in this trial. And the results were quite impressive. As you can see, there was a huge reduction in body weight up to 22% of initial body weight. And what was also interesting in this trial, that the even bigger reduction in body weight was seen in patients with a higher BMI than 35 kilos per square meters, and even more in a woman. So even up to 27% of initial body weight was seen in a female population. Regarding adverse events, the most common adverse events were also gastrointestinal adverse events, who are, like in all drugs, dose-related, higher doses, more adverse event, and but they were mostly mild to moderate in severity, and there was lower in those that were gradually titrated from the smaller to higher doses. And there was also seen dose-dependent increase in the heart rate. It was observed on some 24th week of the treatment, but after that decline, and it wasn't a problem to the end of the trial. So if I may conclude, the treatment of obesity is very difficult. It requires a lot of multidisciplinary team. It requires a psychologist, dietitian, endocrinologist, and of course that it is not just the point to lose weight, but even most difficult is to maintain that weight loss for a longer period of time. So, but we must work on this, because obesity is a really huge cardiovascular predictor, or in general predictor of cardiometabolic diseases. And that's why, besides the non-pharmacological treatments, we need some new treatments. Maybe some of these will be treatment in the future for obese patients. And treatment of obesity must be prioritized, because it will help not just to delay onset of diabetes, but also prevent to stop cardiovascular complication, or eventually to postpone in these people with obesity, especially if they are combined with diabetes. And with that, I will thank you for your attention.